ventilation. So as you all know that we presented earlier. Well, first, my name is Yahya Ithawi. I'm a consultant neonatologist and a general pediatrician. Also, I do pediatric transport. This is a talk from a series, one of the episodes of series of talk about ventilation. We did oxygen delivery system and monitoring of ventilation, and today we'll do what we call it non-invasive ventilation. So to start with, I'm going to show you some questions that I sent to everybody, and we'll see the response and whether they are correct or not. So I'm going to share with you my screen first because I'm sharing only the presentation right now. So I'm going to go to a new share and we'll share. And I hope that now you guys see what I'm seeing. And if you don't see a monkey survey, please tell me by text or raise your hand. So the question one, if you can see it, saying what is or are the difference or differences between non-invasive ventilation and high flow support. We already discussed the high flow support, and if you don't know it, then you can go to YouTube and check it. First option is ventilation. Ventilation means exchanging CO2. And extending CO2 is used when you have a ventilation. So the first option is correct because it can differentiate between ventilation and high flow. As you remember, flow, giving flow is, the purpose of it is oxygenation. And they are of two types, low flow or mask, which give oxygen less than 30%, and high flow, which give oxygen more than 30%. Despite high flow gives some distension pressure, but it does not cause ventilation. And therefore, ventilation differentiates between CPAP and high flow, because CPAP is providing oxygenation and ventilation, while flow supply is only for oxygenation. So the first option is correct. Second option is incorrect because both of them do oxygenation. Third option is incorrect because only CPAP do ventilation, and the pressure that provided by CPAP is regulated. The high flow nasal prong or mask give distension pressure, but it's not measured, it's not regulated, while the pressure given by CPAP is regulated. And all of you know from previous talk, pressure is provided by flow, while volume is provided by time. So the more time you give to the flow, you get volume. The higher or the faster the flow, you get pressure. And they both give pressure, but only in CPAP is regulated. So the third option is correct. First option is correct. First option is correct. Second option is not. Both of them are flow dependent, so it will not differentiate. So the fourth option is incorrect. Heated, humidified and heated flow is incorrect because both of them do same. So the difference between CPAP and high flow is ventilation, CPAP only, regulated pressure, CPAP only. And you can see there is a little bit confusion because not everybody answered the question, although most of you did selected option 1 and option 2. The other question is, what is the main difference between continuous flow and variable flow CPAP? We will discuss it during the talk. Fluidic flip, correct, because it's different. Generator, correct, because it generates. Work of breath, correct, because it differentiates. Exhalation valve, correct, because it differentiates. Oh, is it? No, so the sound is very good actually. I tested it. The sound are very good. I don't know if others have a problem, but the sound is very good. So please, if many of you has a sound problem, I can try to see the setting is good and the sound is good. So if all of you has a problem with the sound, please notify me. Okay. So, and then the type of the delivery, yes, that differentiate between type of delivery, because variable flow deliver pressure in a different way from variable flow. So you can see that the difference between continuous and viral flow is all of them. But the RAM cannula, you cannot, any cannula, you cannot use it with CPAP. You have to use the generator to be variable flow CPAP. So the main difference between variable flow and is the generator, or the things that we put it on the nose. So you can see that there is a little bit of confusion between. Who's trying to connect? Or somebody is trying to call me. Mason, can you speak with Samira from, I think from Fallujah? She's trying, she does not know how to enter. And I've been waiting for 2 days to help people to know how to enter. Okay, so I will start the real presentation. We'll do another share. Okay, so today we will be talking about non-invasive ventilation, and I hope that everybody is seeing what I'm seeing. And the objectives of today's talk is to define non-invasive ventilation, to talk about the interface that connect the machines to the body, and what are the types of non-invasive ventilation. We'll talk a little bit about continuous flow CPAP and bubble CPAP and variable flow CPAP. We'll talk about setting, how to set a CPAP. We'll talk about benefits, predictive of failure, and we'll talk about complications, and hopefully we can answer some questions at the end. Okay, getting chat. Well, asthma is not the time to talk about the setting. I've been waiting for 30 minutes. So no more talk about how to connect right now. It's only about the lecture. So my apology. You can ask somebody else to help you. So we'll start with definitions. What is non-invasive ventilation? It's providing ventilation or breathing support without ETT, without endotracheal tube, as simple as that. Non-invasive, there is no ETT. It can be connect the machine through nasal prong, or through mask, or can be through face mask, or it can be through a helmet. And in general, non-invasive ventilation are two types: either continuous positive airway pressure, or we call it CPAP, or bilevel positive airway pressure, BPAP, or some people call it advanced CPAP. So there are mainly these two, and there are other types are generated from some of them. Okay, I'm trying to answer asthma, because asthma is asking me a technical question, and we've said many times. And the other problem is most of you putting the title doctor. The title doctor is not required because it's confusing. Everybody putting doctors, then everybody will start with same D, and I have difficulty in reaching you. So now I want to find asthma. Asthma, I cannot find her because maybe she put the word doctor. Okay. If somebody know asthma, please help her to connect. What CPAP offers? It offers mainly two things. It offers oxygen, so it decreases work of breathing. And second, it stents upper airway and it decreases work of breathing. So it reduces the work of breathing by providing oxygen and stenting the upper airway. Also distending the alveoli. All of that will provide better oxygenation and then reduce work of breathing. And second, it provides ventilation, or it improves the gas exchange. And by connecting the CPAP, you will simply avoid ATT, because we've said CPAP, or non-invasive ventilation, is providing breathing support without an ATT. And because there is no ADT, then you don't need sedation, and you will not need muscular and neuromuscular blockade or muscle paralysis. And you will avoid, of course, by avoiding ATT, you will avoid invasive mechanical ventilation. When we use CPAP, almost anywhere, but it's mainly needed for transport, for emergency department when the ventilator not ready. We can use it in PICU, or we can use it as a start, but also we can use it as a step down from ventilation when your ventilation is not. Well, Abir, if you only have first slide, then your internet is slow because I am on the third slide. If all of you see only the first slide, please tell me. As somebody saying that's only first slide. What? No, we are on the third slide. All of you see only first slide? Okay. Sounds good. Let me see what's happening. Okay. Sounds good. I understand all of you see first slide. Okay. Let me see what's happening. Okay, 1 minute. Do you guys see now? Do you see guys now? Okay, sounds good. So everybody now you can see. So I'm gonna recap that very quickly. Okay, sounds good. This talk about non-invasive ventilation. So the objectives will define non-invasive ventilation. We'll talk about interfaces. We'll talk about types of non-invasive ventilation. We'll talk about continuous flow CPAP, about bubble CPAP, about variable flow CPAP, about setting of a CPAP, about the benefit, and about how the CPAP can fail and the complications. So we said definition. We said that non-invasive ventilation is any respiratory support without an ETT. So because when you have ETT, it's a invasive support, and so to connect to the patient, you can connect that CPAP with interfaces. It can be nasal prong, can be mask, or it can be face mask, or it can be helmet. In general, they are of two types, although there are other types, but in general, it's either continuous positive airway pressure, or CPAP, or bilevel CPAP. Bilevel means you're giving PEEP and PIP. What it does, it decreases work of breathing. How? It stents the upper airway. It provides oxygen, and it inflates the alveoli to improve oxygenation. But also, it improves respiratory gas exchange, which means the CO2. And by giving CPAP, you are avoiding the complications of having the ETT on board. And because you don't have ETT, you will not need sedation. And you will not need neuromuscular paralysis. And of course, you are avoiding the invasive mechanical ventilation. When to use it? It's almost anywhere, but it's mainly we use it in transport or in emergency department where the ventilator is not set yet, but also can use it as in a PICU in mild cases or in certain selected cases of respiratory support. And also you can use it when you extubate, when you step down from invasive to non-invasive, because sometimes baby is ready to extubate, or the patient or the child ready to extubate, but he's not ready to be on room air. So non-invasive ventilation can be stepped down from the ventilation. So the main confusion comes between non-invasive CPAP and flow. And as we talked in the previous episode about the oxygen delivery system, the flow is of two types, the high flow and low flow. Low flow is the flow less than 4 liters per minute, while high flow is more than 4 and more. So the less than 3 will give you only 30% FiO2 but high flow will give you more. So the main difference is between non-invasive ventilation and high flow oxygen delivery is this provide only oxygen, while non-invasive provide both oxygen and ventilation. Both should have heated humidified oxygen in non-invasive ventilation and in flow oxygen delivery. The difference is there is no ventilation. High flow also, because it's high flow, and remember we said pressure is flow. So the more flow you give, you get pressure. But this pressure is unregulated, unmeasured. While in non-invasive ventilation, the pressure is measured, is regulated by valves. So the main difference for non-invasive ventilation and flow oxygen is regulated pressure and it provides ventilation. While flow oxygen, it provides only oxygen, but the more flow you give, you get pressure, but this pressure is unregulated. So you get side effect of the pressure, but you don't get the benefit. The interfaces is how you connect CPAP to the patient. There are different ways. There is nasal cannula or nasal prong, and there is nasal mask. It's mask over the nose, and it's of course of different sizes. And you can use a full face mask, and usually we don't like to use it in CPAP, not a preferred method, but that's also another option. You can't hear me. Marwa, you cannot hear me. Is everybody else can hear me or only Marwa? Do you guys hear me? Okay. Everybody, Marwa, can hear me. So you have the problem, not from me. Everybody is hearing me. So the other way to provide oxygen is by helmet. Okay, I got it. Everybody can hear. Only Marwa has a problem. So the helmet is a mask, is another way of mask, but it involves the whole neck. So it's something like oxygen hood in nasal or in flow oxygenation, but that's where you can provide CPAP. So this is what we call it helmet. How we select the interface? It should be comfort. It should fit where we are applying, and should minimize the side effect. And these side effects can be local and can be general. So we have the face mask, we have the nasal mask, we have nasal prong, and we have the helmet. When we provide or connect the machine to the patient through an interface, then we have to protect the skin. The best that we use to protect the skin by providing hydrocolloid gel. It's like a tape with a chemical substance to protect the skin and provide less irritation. And you can see they used it here. The other way to protect the skin is by using cushion. So it's cushionied air or gel. You can see air and you can see gel. And that will distribute the pressure from the interface to a wider surface area of the skin and hence provide less pressure injury. Also, we have different sizes. And by using different sizes, we will have a better fitness. when you use appropriate fitting interface, you get less injury. The other way to provide less skin injury and protect the skin is by cycling. So let's say you use 8 hours nasal prong and 8 hours mask, and then you cycle between both to provide less skin injury. The other, so we talked about using the appropriate interface. We use hydrocolloid gel. We use appropriate fitting mask. We use also air or gel cushion, and we fit. We use the appropriate size, and also you have very good fitness. The best to fit the mask is by provide 2 straps, and providing 2 straps distribute the pressure from the interface on the face evenly, and it provides less injury. And there are different ways of doing the straps depending on the gestational age. We have a question. Okay, Najwa is not seeing any slide. Do you guys seeing the slides or not? Are you guys seeing the slides? So Najwa, everybody is seeing the slide, then you have the problem. Everybody is answering me, you're seeing the slide, so you have the problem. So everybody is seeing the slide, Najwa, it's only you. So you need to fix it yourself. So by fixing the interface appropriately on, then we should use 2 straps. And these straps change, it depends on the gestation. It's usually in a neonate, we use a hat to connect the CPAP or the mask. And also it has 2 connections, 2 straps. In this area, they can see 2 open straps, and these straps are connected in some way. You can see that's another way of using a hat. So the straps are connected to a hat, not like the other one. It's directly on the head. So what are the types of non-invasive ventilation? The first non-invasive ventilation is CPAP. What is CPAP? CPAP is a continuous positive airway pressure. What does that mean? Continuous airway positive pressure is any pressure above atmospheric pressure. Asma cannot see the slide. Asma, you should have come earlier so I can help you. Right now, I cannot help you, unfortunately. So CPAP is providing pressure. So what is providing pressure mean? It's any pressure above atmospheric pressure. For purpose of ventilation, the atmospheric pressure consider 0. We know it's 760 millimeter mercury or 1024 centimeter of water. That's the atmospheric pressure. But for purpose of ventilation, atmospheric pressure consider 0, which means any pressure above 0 is considered CPAP. So what is CPAP? Is a distension pressure. What's distension pressure? It's the pressure that open up alveoli. And this pressure is provided same through the whole respiratory cycle. No matter what is the respiratory phase, the CPAP is continuous. Whether it's inspiring or expiring, inhaling or exhaling, the pressure is there. And it's equivalent to PEEP. And PEEP is the pressure that keeps alveoli open, or positive and expiratory pressure. But they are not the same. PEEP is the pressure inside the alveoli, while CPAP is a continuous pressure above atmospheric pressure. So CPAP is a continuous pressure. Non-invasive positive pressure ventilation is So CPAP is continuous. Okay. The other way to provide non-invasive ventilation is by providing non-invasive positive pressure ventilation. Positive pressure ventilation means you have two phases. Remember, in CPAP, we have only one phase through the whole respiratory cycle, while non-invasive positive pressure ventilation is providing two phases. And these two phases can be synchronized, can be not synchronized. What is synchronizing? Because remember, when we ventilate, you have two types of breaths. First is mandatory, which is the, and second is the spontaneous. What is mandatory mean? Is the breath that the ventilator provides. And spontaneous, what the patient is doing. So when you match the mandatory provided by the ventilator with the spontaneous done by the patient, we call it synchronized. You synchronize both. So again, non-invasive ventilation is providing there is no other room, it's only one room. They are doing a personal request meeting. Mason, there is no other room. They are calling me. They are not entering the meeting room. They are calling me personally on Zoom. So I cannot be on too. So non-invasive ventilation, it's a two phases of pressure without an ETT. And remember, as we talked, there are two types of breath, spontaneous and mandatory. And mandatory is provided by the machine, spontaneous by the patient. When they are matched, it's called synchronized. So non-invasive positive pressure ventilation, or NIPPV, is assisted ventilatory pressure synchronized with spontaneous. And usually the synchronization of mandatory with the spontaneous is provided through backup rate. What does that mean? Is we will say, I will help the patient with his spontaneous breathing. But if the patient does not breathe at least 20 times per minute, I'm going to provide him with these 20 times. So when the patient starts to breathe 21, it will be supported. When the patient will be providing 19 will be provided, and the machine will give one extra. So that's what's called backup rate. And the non-invasive ventilation is of two levels, which means two sets of pressure. The inspiratory pressure, or the pressure providing during expiration, or we call it IPAP, and the pressure providing during expiration, what we call it EPAP. The BiPAP or BiPAP in capital are the term used for delivery of bilevel CPAP. And bilevel CPAP usually provided by a ventilator, but without an HET. What are the indications of CPAP? Many indications. I'm not gonna go through, but as we said, it can be transport, it can be prior the ventilation or step down from the ventilation, and there are many there are many types of upper and airway indications. You can read it, but we don't need to go through it. Contraindications is when you need ETT. You have resuscitation and you have arrest, or your mental status is impaired. Your GCS is less than 8, or it's rapidly dropping, or you have an air leak, whether PIE or pulmonary interstitial emphysema. We'll come to that, Hajar. We'll come to the types one by one. I just said the general, but we will come to the types one by one. And when we go to that, you will understand it. But in general, there are two types. There are continuous and there are bilevel in general. So these types it was a general. We will talk about each type. And also we will use it when there is risk of aspiration, like hydrocarbon inhalation, like recurrent vomiting, like upper airway malformation, tracheoesophageal fistula or something. And also you need contraindicated when you need to protect airway. So if a patient cannot manage upper airway, whether it's a central problem or it's an upper airway problem. Interstitial emphysema, use CPAP or not? It depends. Usually not, but sometimes you can. So for example, if you have a chronic lung disease with interstitial emphysema and your baby is ready to extubate, then yes. But in general, interstitial emphysema need ventilation. But sometimes, yes, as a step down from ventilation, you can use CPAP for interstitial emphysema. So again, the indication is risk of aspiration, need to protect upper airway. It's better to avoid in hemodynamically unstable. And what does that mean? When you need inotropes. So if you need inotropes, mostly, please don't use CPAP. Also, when you have a GI bleed with the risk of ventilation, or you have a facial injury, or you have a severe pneumothorax and you cannot treat it. Although sometimes I use CPAP in pneumothorax in a control situation. But in general, CPAP should not be used with pneumothorax, with some exceptions. So now we'll talk about one by one. What are the types of CPAP? And what are the types of non-invasive ventilation? So the first type of CPAP is what we call it continuous flow CPAP. And there are two types of continuous flow CPAP. It means continuous flow, continuous positive airway pressure. There are two types of continuous flow. The first one is called bubble CPAP. And bubble CPAP research and gained lots of popularity in recent years. And I'm sure some of you knows that medicine like a fashion. It's like a hairstyle or a dressing. Some things go up, and suddenly disappear. So bubble CPAP gained a momentum in last years for using it. And the reason because we have lots of bronchopulmonary dysplasia in neonatology, and people trying to do many things to prevent it. And there are many center things that bubble CPAP can prevent bronchopulmonary dysplasia. However, remember, bubble CPAP, and we will talk how we can do the bubble CPAP. There are a lot of leaks from bubble CPAP. There are many areas in the system can leak. And the problem, you cannot measure the leak. And because it's a manual setting, so it's subjective to error. So and remember when we talked about CPAP and flow nasal, again, we said it's a regulated pressure. It's a pressure that you can measure. And because the measurement of bubble CPAP is not that accurate, then this is another problem. The other problem of bubble CPAP is the control, the pressure, because remember, the pressure always generated by flow, and the flow should be blocked. And usually with the CPAP machine, the block is the exhalation valve. In bubble CPAP, the block is the fluid, the water that we use. And because the distance between the interface and the fluid is a little bit long, then the patient, when breathe out, it will breathe against that column of circuit, which contain the pressure. And therefore, it increases work of breathing. Now, we set the CPAP by blending air with oxygen, and the oxygen should be heated, and then humidified it, and then inhale it to the patient through nasal cannula. And the pressure is because we have a flow, the pressure is generated by blocking the exhalation tube. And the blocking happens through a water. So you have this circuit, and then you have a segment that fit in this tube circuit, and this segment is marked with 1 centimeter scale and 1 centimeter scale, and you can see the tube or the bag or the container also marked, start from the level of the water by 1 centimeter each. And then you dip this segment inside the water. So more you dip, the more centimeter you get. These centimeter will block the flow and will give you how many centimeter the patient is getting. So if you go by 3 centimeter, you are giving 3 centimeter of pressure. If you go by 5, 6, and on. So you can see it's subjective, it's not measured, it's only from this way, and it's labor demanding. So you need people to keep watching it. And the, okay, we have a question. How much water? Are you talking about chest tube? This presentation is not about chest tube. This is bubble CPAP. This is not chest tube. So if you're asking about chest tube, we can answer that after the presentation. Today, the talk is not about chest tube and how much suction pressure and how much water you should use. That's a different talk. That's a different discussion. But if you're talking about, yeah, I'm trying to explain. No matter the water is how many centimeter you are dipping. So you can fill the water in here, you can keep it in here. But your measurement should start from the surface of the water. Whether it's in here or in here or in here, it's how much you are dipping. So wherever your water is, if you are marking it yourself, no matter what. But if you are using a make or a company designed bubble CPAP, you should fill it at the mark, because you can start marking from here, you can start marking from here. Is no matter where you how much water, it should be at the first mark. So this is 1 centimeter, 2 centimeter, 3 centimeter. You can start from here, put the water and start 1 centimeter, 2 centimeter. And then this segment of the tube is also marked by 1 centimeter. So when you dip this, because this can fit inside, so if you push it up or pull it down, and then measure how much centimeters you are dipping. Oh, no difference. Oh, it has nothing to do with the level of the patient. This container can be up, can be down, it can be same level. The container from the patient has nothing to do with. It can be up, it can be down. It's the segment that is dipped in the water is the measurement. Because we're not comparing the with atmospheric pressure. We're considering atmospheric pressure is 0. Okay, Shayma Abdel Tawab, you want to control my camera. Why? You had, this is the third request from you to control my camera. You cannot control my camera. Of course, I will not accept. So I'm declining your ask. So please stop requesting to control my camera. So again, the level of the container from the level of patient have no problem. It can be above at the same level of below, because we're considering the atmospheric pressure is 0. The dipping distance is the what we should measure. Of course, you have a ready-made bubble CPAP, but you can do CPAP your own from giving sets and from giving from bottles, fluid bottles. You can set your own. You can mark. You can use giving sets, connect to the nose. If you have a humidifier and you have a blender to blend air, medical air with oxygen, and you can do your own. And there's YouTube's many people, respiratory therapists, explain how you can make a bubble CPAP from scratch. This is the heater and the humidifier of bubble CPAP. The other type of continuous flow CPAP, what we call it ventilator drive CPAP. So you have the interface, you have the tube circuit of the ventilation, and you have a ventilator machine to provide you the CPAP. And we know how we provide pressure. It's flow blocked. So when you have a flow and you block it, you get pressure. That's one way of measuring. There are Venturi way of making a pressure, but that's the way we use the pressure, how to make pressure in the ventilator. Which means if you have a flow, and so you have inflation, you have the inspiratory tube, goes to the patient, and then back to the machine, you have exhalation valve. And when exhalation valve block, you get pressure. When the exhalation valve open, you don't get pressure. And if you control that exhalation valve, you can control the PIP and PEEP. So how we provide continuous flow CPAP is using a ventilator that's used for invasive ventilation to provide us with the pressure. So the ventilator provides continuous flow. And of course, the ventilator have two tubes going in from other side. One is air and one medical air and one is oxygen. So it's blended inside the ventilator. And the pressure of the CPAP from the ventilator is modulated by the expiratory valve at the expiratory port of the ventilator. Of course, if you have what we call it NICU on the valve, which means the valve is control itself how much in and how much out. It's exactly the same of the injector that we use in the car, the new cars. The advanced cars is when you press more on the fuel pedal, you get more opening and you get more fuel going to the engine, and it's faster and faster and faster. So it's exactly a new valve. The exhalation valve of new machine have a control system. The more pressure you need, the more closure of the valve. The less pressure you need, the less pressure. So it can modulate itself. That's the new. But some of them they don't have. That's why it will determine. This will determine the price of the machine. So how you control the pressure from a ventilator is you control it by the expiratory valve, and the other one from the inhalation port of the circulation circuit. If you provide more flow, because remember, pressure is a flow, and there is a block, and there is something blocking it. It provides you also with higher pressure when you get more flow, so you can control the flow of the ventilator and give you more pressure. And also the pressure transducer, we're switching between pressures. That transducer can also help you with the pressure. These three ways can control you and provide you desirable level of CPAP. How many centimeters of water? Of course, has no leak because it's all sealed. And the other thing is simple and rapid. So if the baby ventilated and you extubate, you put them on ventilator and use same machine. Or if the patient is on CPAP, you don't need to switch the machine. You intubate and use same machine. So it's very important, very good when using continuous flow CPAP through ventilator provided. It's easily to transit, step up or step down from ventilator. The problem is increased work of breathing, because the patient, remember, there is in circuit part of the circuit and out from into the nose and or to the mouth and out of the mouth. And because you're not using a control or a generator, the patient will breathe. And remember, the flow giving you to the patient, give the oxygen, and back to the machine, there is exhalation valve to provide you the pressure. So that means the patient will breathe from the nose to the ventilator. Again, it's that whole tube. And therefore, there is increased work of breathing. The other disadvantage is you cannot use it with the generator. And the generator is at the nose. We'll talk about what is the generator. So these are the disadvantage of continuous flow CPAP. And also continuous flow CPAP, whether it's a bubble or it's a machine delivered, you cannot use it with generator. Either use it with nasal prong, or use it with a mask, or you use it with ram cannula. So you cannot use the generator with the continuous flow CPAP. Variable flow CPAP is another way. It's not a ventilator. It's a machine by its own. And it can be CPAP, or some people call it CPAP, some people call it advanced CPAP, because it's provide, or it can be continuous. So it's a variable flow continuous CPAP. Remember that a continuous CPAP is, so we have continuous flow, continuous positive airway pressure CPAP, and variable flow continuous positive. So although it's continuous, but it's a variable flow. What does that mean? It's confusing. And you have bilevel continuous variable flow CPAP. So there are a little bit of confusion here. So we have continuous positive airway pressure, but it's a variable flow. And variable flow CPAP, it can be continuous, it can be, standard CPAP, it can be high bi-level CPAP or advanced CPAP. It decreases the work of breathing because we do not have expiratory valve. We have a pressure generated by the machine through a flow to the generator. And from the generator, when the patient breathes out, it will breathe to another port. It will not breathe back to the machine because of the generator at the nose. And that makes the difference between variable flow, continuous CPAP, and continuous flow, continuous CPAP. So the variable flow, the whole issue, the whole matter is at the nose. And therefore, it cannot be used with the nasal prong per se or mask per se. It should be used with a specially designed nasal prong or specially designed mask. And there should be nasal generator. And the nasal generator should use fluidic flip. And we will talk about what is generator and what is fluidic flip. So the whole difference between variable flow and continuous flow, continuous positive airway pressure or CPAP is at the nose. The fluidic flip, when the patient breathes in from the port of the circuit coming from the machine, it goes to the nose. But the generator at the nose designed in a way when the patient breathes out, the flow from the machine go out. And therefore, when the patient breathes out, it will not breathe against the machine. And therefore, you have decreased work of breathing. So during inspiration, he will get the pressure. During expiration, he will never get the pressure. And that's what we call it variable flow CPAP. And it's that happen, the fluidic flow principle is fluidically moving the air away from the machine during breathing out is by this. So the flow goes through exhalatory valve during expiration and go to the patient during inspiration. And it's controlled by this jet stream. So the flow in, flow out, flow in, flow out. And that's what we call a generator. And it differentiates between continuous and variable flow CPAP. How we deliver CPAP to the patient? We can use nasal mask. And we have different size of nasal mask. It depends on the size of the patient. We should seal it very well. We should fix it very well. And sometimes it's difficult to fit, but it decreases the injury to the nasal septum. It causes pressure sore, pressure problem, but decrease the damage to the nasal septum. Also, we can use nasal prong, and this is the most commonly used, and usually we use it post-extubation, but we switch it with the mask or nasal mask, either to alternate or when we start to have nasal issues. And most of our unit, we cycle between mask and nasal CPAP. The other way is to use nasopharyngeal CPAP. How we use nasopharyngeal? This is very important for transport. So you bring ETT, and usually we immerse it in milk or breast milk, and we cut it, and we put it through one of the nares, we close the other one, and we connect it to the CPAP. But of course, this will not be variable flow CPAP because you cannot use the generator. So you have to connect it to a machine, ventilator machine. So this is an alternate to nasal prong. Okay, I have a question. Oh, we just said that there is no indication which one you use. Mask has more pressure because you need to fix it very well. So it gets more pressure on the face. While nasal prong, you don't need pressure. But nasal prong will press on the septum. So you'll have more septal injury. So most of unit use nasal prong post-extubation. When you start having septal problem, you switch to the mask. But some of the units switch between nasal prong and mask CPAP. Because nasal prong is less pressure. You just put it in and that's all. You don't need to affix it very tight on the face. And then you will not have a pressure on the face, pressure injuries. But also you might have septal injury. So we start with nasal prong. So using EGT through the nose, blocking one of the nares, cutting the EGT, immerse it in a milk, and use it as a nasopharyngeal CPAP. The other way of providing CPAP is using EGT. So sometimes you want to extubate the patient. One of the ways to extubate the patient is to test spontaneous breathing. So you shut up all the machine, you're just providing continuous pressure using the ventilator CPAP through the EGT. And the patient will see the patient breathing or not, what we call a CPAP trial. But the other ways to doing is doing positive pressure mode of ventilation, or PSV. We will talk about ventilation in other talk. But one of the way using CPAP is connecting it to the EGT to do a CPAP trial as a trial to see if the patient is a ventilated patient, whether it's spontaneously breathing or not. Now, what is the non-invasive positive pressure ventilation, or bilevel CPAP? As we said, it's providing two-level CPAP through an interface, but the interface is not EGT. So it's a ventilation providing PIP and PEEP, but through the not EGT that way going inside the lung. So that's what we call it non-invasive positive pressure ventilation. Of course, there are two types of non-invasive positive pressure ventilation. There is the conventional and there is the high frequency. But I'm not going to talk about high frequency non-invasive ventilation today because I didn't speak about high frequency yet. We're talking about non-invasive conventional. So what does that mean? It provides two-level CPAP. Remember, we talked continuous CPAP, and it's a continuous and variable flow. And now we're talking non-continuous, bilevel CPAP. So it provides two levels of pressure, PEEP and PIP. So the expiratory pressure, or expiratory PAP, positive airway pressure, and usually it's a 5 centimeter. It's the pressure to keep alveoli open and stent upper airway. And there are another pressure that we set, we call it IPAP, PAP, which is inspiratory positive airway pressure, and usually it's about 8 to 10 centimeter. And then you titrate up and down both pressures to get what you are looking to get. So this is an example of non-invasive positive pressure ventilation. You can see that you are setting the IPAP and EPAP 8 and 14. You are setting the rate. What is rate? The rate is the number of IPAP per minute. And usually we set it at 20. And because we have a rate, you should have inspiratory time. How long IPAP is going? So it's a 20, but how much IPAP and how much PEEP? So if you set your I time to 0.6 and you get 20, if you multiply 20 by 0.6, you get about 12 seconds. So the rest of 60 seconds is for expiration. And then you need to titrate how much FI2 or how much oxygen you're getting. So in bilevel, non-invasive ventilation, you set your EPAP, your IPAP, and then you titrate up and down according to your response. But usually your IPAP should not exceed 22. You also have to titrate how much oxygen you're giving. The less oxygen, the better. The best would be room air, 21%. And then you need the backup rate. And this depends how much patient are breathing. If the patient is breathing normally, you don't need to set any. But if the patient is not breathing, you need to set the rate. Usually we go with 20, most of the units. And then you need to talk about sedation. Now, I have one slide about sedation. The best sedation that I recommend for CPAP is dexmedetomidine. The dexmedetomidine is very good sedation method for CPAP for only one reason. It does not cause respiratory depression. And for those who does not know what is dexmedetomidine, it's alpha receptor agonist. Alpha receptor is of two types, type 1 and type 2. This one is a selective type 2. If you guys know the clonidine is non-selective, and it work on. And the clonidine, we use it in a patient with drug withdrawal. We use it in stimulating growth hormone tests, and also we use it for hyperactivity syndrome, ADHD. And it's same with the guanfacine. Guanfacine and clomidine is very, but guanfacine usually used for adults and use it also for some of the depression and psychosis. Dexmedetomidine is selective and it causes no respiratory depression. We have a loading dose and we have a continuous infusion dose. The other one is I recommend is midazolam. I do not recommend diazepam. I do not recommend lorazepam. Lorazepam causes myoclonic jerk, especially in babies less than 33 weeks. And it's longer action and has more respiratory depression than midaz. Midaz still have some respiratory depression, still might have some clonic abnormal twitching side, but it's less than lorazepam. Diazepam has a long, and even it can hang over the timing. Dexmedetomidine is only about 2 hours, the longest duration of action. Usually it's about 20 minutes. The other way to give sedation is chloral hydrate. It's an oral sedation. It's a conscious sedation. It can cause, it does not affect the breathing, so it's also another way to sedate during CPAP. How you assess the effectiveness of CPAP? You look at the respiratory rate. You look at the heart rate. You look at the work of breathing, especially where you're using variable flow or continuous flow. You have to look at the work of breathing. How much oxygen? Do you have a hypercarbia? And you can do an X-ray. Now, there is something what we call it CPAPophobia, people afraid from giving CPAP. I recommend CPAP up to 15, 15. And why is that? Because there is a very good study done in Australia showing you that at level of 15, the alveolar distension gives you the maximum contact between the alveolar wall and the capillaries or the pulmonary vasculatures. After 15, you will not get that distension pressure. Below 15, you get less contact. So when you deflate the alveoli, you get less contact between the alveolar wall and pulmonary vasculature. If you give more distension pressure, you get more contact. Of course, to give higher level CPAP, you should have a machine that's able to do such, and you have to have a good monitoring. So you do an X-ray. What is the best of X-ray? You show the degree of inflation. So you look at how is your diaphragm is flat, how many ribs? 15 centimeter of water. I mean centimeter water. 15 level of the CPAP. You can reach CPAP up to 15. You start with 5 and increase. You can reach up to 15. After 15, you will not get benefit because no matter you do, you will reach the maximum contact between distended alveoli and the capillaries. Below 15, you get less contact. Of course, not all the patients you need 15 when you require. It depends on your FI2, your work of breathing, the patient tolerance. But I mean 15 or 1.5 is the centimeter water of the level of CPAP. 15 in a newborn, in a premature baby. Yes, 1.5 in a premature baby. And that's what I called it, CPAPophobia. As Hussam Subhi is asking me, is 15 in a newborn? Yes, in a premature baby, 1.5. There is no reason for CPAPophobia. Or not all the time if you need it. If you need it. If you need CPAP and you want to avoid intubation, a unit. But I do not prefer level 15, for example, on first day or second day. Have more questions? Oh, way we go more way, man. It's just an easy we go to 11. Like our mean or average, our average is 11. In our unit, is our average is 11. We rarely use 4. Sometime when we step down, you go to 4 sometime, but we rarely use. Usually we start with 5 if you have obstructive apneas or, but if you have a respiratory problem, the standard is 6 and then you go up. And I do not advise above 8 in first few days, like in first 3 days of life, but after 1 month, you can go up to 15, 1.5. And our mean in 1 month old, the babies needed CPAP is 11. How you predict you are failing? It depends on the cause. You have asthmatic and you have no response. You have upper airway obstruction. You are thinking of epiglottitis. You are not responding. On Tasneem is asking me by 15, you mean PEEP? Please do not mix between CPAP and PEEP. PEEP is the pressure required to distend the alveoli. CPAP? No, I am not speaking about PEEP. I'm speaking about CPAP. Please do not mix up between PEEP and CPAP. CPAP is the pressure above atmospheric pressure. It's a continuous pressure. PEEP is the pressure required to keep the alveoli open. So by providing CPAP, you will get adequate PEEP, because PEEP are of 2 types, if you guys know, the effective PEEP and the PEEP. So when you're providing CPAP, you get good PEEP. PEEP is different from CPAP. But when you use bi-level CPAP, you can provide IP, PIP, and PEEP. It's a CPAP, but it has PEEP and PIP. When you do giving continuous CPAP, you don't provide PEEP. You're providing continuous, whether the patient has PEEP inside or has PIP. So CPAP is not PEEP. But when you give good CPAP, you get PEEP. I'm talking about the level of CPAP, not PEEP. When you use bi-level CPAP, your PEEP should be 5 to 6. Maybe you can go up to 8. And your PIP in bi-level CPAP, you can reach between 15 to 22. I'm talking about straight CPAP, plain CPAP, just CPAP. When you give good CPAP, you get good PEEP. But CPAP is different from PEEP. So I'm talking about CPAP. You can reach up to 1.5, 15. After that, you won't get benefit, you get side effect. So how you predict failures from underlying cause, and then from grading your disease severity, like grading of asthma or bronchiolitis, and how whether the patient is responding to treatment or not. What is the benefit? Is to avoid invasive ventilation. And you can avoid up to 100%. All your patients can avoid ventilation by using a proper CPAP. For example, when I said 15, everybody was scared and start to ask, because they are not providing a good CPAP, therefore they have more risk of ventilation. So the risk of avoiding, the benefit of avoiding ventilation is between 60 to 100%. What are the complications? There are major, like barotrauma. What is barotrauma? Is distensibility of alveoli. What is, barotrauma is shearing, breaking the walls. So if you have a closed door and you get pressure inside the walls, at the end your window will be broken. That's a barotrauma. But if you are inflating balloon and inflate until you reach a point, when you deflate, it become very dispensable. It will not go back to its original shape, and that's the volutrauma. So there's risk of barotrauma, although very low. You can get aspiration because you are distending the airway, while at the same time you are distending the GIT. And also you can have some, you can, but if CPAP does not work, usually bi-level CPAP does not work. Yes, you can try. There is no science, but you can use CPAP for apnea, but you can use bi-CPAP. You can trial and error. There is no science behind it. People saying there is no difference. But a good CPAP You will avoid, if you use a good CPAP, you will avoid bilevel CPAP. But yes, you can use for bilevel CPAP for apnea. You can use nasal high frequency for apnea too. So it can cause hemodynamic instability because you are not ventilated. And other is minor skin breakdown from the mask over the skin or from nasal bronch, the nasal septum. You can get gastric distension, so you need to put feeding tube and aspirate it. And if it's not fitting well, you can get some eye irritation or eye injury. What other non-invasive ventilation? We talked about it earlier when we talked about the oxygen delivery systems, is flow inflated bag. You can provide a non-invasive ventilation. And you can use self-inflated bag. You can mostly in resuscitation, or you can use the TPs. We talked about the TPs, which is a kind of flow inflated bag, but it's more controlled. And I am done for non-invasive ventilation. I'm waiting your questions.